right?
Yeah.
It has something to do with switching.
Yeah.
You know what? Here's what I'd like to do. If we could,
We'll just wait for
when she gets here, I'll pass them all out. You can look at them, and then I really want to go over several of them and move over that one too.
Okay. So it's like I think I understood the concept, but I don't think because we were just talking about it.
I think it's something to do with not all people who are switched are schizophrenic, but everyone who's schizophrenic is switched.
It was just such extreme.
Yeah, and actually, I think it's true. I think the answer is true. Was it a most or was it
There's
a?
a many and there was most.
I read it and thought of Ellen. I was like, Ellen. Oh my god.
I wouldn't know what to say.
We'll look at that one.
Okay.
Yeah, we'll go over that one because I graded the M1s and I'm more familiar with that test and Alyssa graded the L1s. So we'll go over that and because I mean the tests, excuse me, are really excellent learning tools. We go over them like that. But yeah, we were able. I was actually very pleased. It always, for me, it's like there's some of the questions that we really didn't cover very well, and really, if you weren't here every minute of the 100 hours, you could have easily missed some of those things. But then a lot of the stuff was pretty straightforward. And some of the ones that some of you missed were really surprising because I knew you do it. But yeah, so everybody passed, and that doesn't happen too often. Now, last time we did it, we only had I think 7 or 8 people. Everybody passed, which was that might have been the first time that everybody passed who took it in the class I taught. Anyway, today I have some more stuff to go over, and I was hoping we could workshop. We didn't really workshop yesterday at all, and because it's the last day and the test is done, all that, we can kind of do what feels most productive. We can go through some treatments. I'd be happy to go through maybe some different stuff, try to weave together what we've learned over the months. And
I have a suggestion.
Yeah.
Maybe some adjustment.
Sure, I love talking about adjustments. So.
I would love that because I don't know how to do the fixations. I don't know how to adjust that accurately, I guess.
Yeah, we can go over that. I mean, if you don't know how to do it, then probably somebody else may not know how to do it.
I'm very far removed from the phys med classes, so those who are in it probably are better at it.
I'd be more than happy. Fixations are super important, and you'll use them a ton in practice. I mean, subluxations I think are harder to understand, but probably have a more profound effect on patient's health. And subluxations are treating a subluxation is just different. Adjusting for subluxation is different. Different approach. You're dealing with different anatomical. So, yeah, that'd be great. Yeah, we could talk too about extremity adjusting. I know I've done some in different times, but I could kind of go over like maybe shoulder, knee, hip, ankle, and show how I would determine where I would adjust and what kind of adjustments you can do to those structures. So we talked about blood pressure yesterday. Anyway, whoever showed up after, I'm just talking about the exam, and everyone did pass. So make sure we have the right the name as you want it to appear on your certificate. Because what I'll do is I I go online and I put all your data in with the ICAK, and then they print the certificates. Now, they won't mail them out to individual recipients, which is, I guess, probably because it's too expensive for them or too much office work or something. So they'll all come to me. So I'll have to make sure I have current mailing address for each one. Or maybe one, maybe two. I have a secretary. Who's your secretary? Yeah.
She's not in this class right now.
Oh, okay.
She's in class.
So anyway, so if I could get a good combination, I have addresses and emails. I don't have that this year for some reason. Usually I have like a what you call it, grid thing. So we turn off that line.
Yep. Because I put it on for the mail.
Oh, sure. Yeah, I have those.
Yeah. Oh, that's even better. Yeah, it's crazy. I don't like it. That bathroom I walked in on literally it gave me a jump scare. Yeah.
Just a problem. Yeah, perfect.
Is that okay for everyone?
Yeah,
Too dark?
it's perfect.
Okay.
So,
Honestly.
so we talked about blood pressure. I'll run through these slides. And one of those questions on the test was about glabellar fault, and I kept bringing it up because I use it so much for blood pressure, but several people missed it. So I don't know. Dr. Francis, he would always take blood pressure on both sides and see if there was a difference. And he was always looking to see if there was any kind of noticeable difference between one side and the other. And then he'd correlate that with girl torque issues and things like that. But anyway, Nora, you guys, I'm sure know all this. And we talked about this back when we talked about adrenals, but normally the blood pressure should rise 5 to 10 points systolic or diastolic or systolic when go from supine to standing. That's considered a normal response. And a lot of that is accomplished by, of course, the epinephrine. We get this little shot of epinephrine that quickly brings our blood pressure up to accommodate the need, because now the brain is going to be way above the heart kind of thing. So that's normal. Now, if someone's blood pressure stays the same from supine to standing, that's pretty good. Some might consider that to be a positive Ragland's, but honestly, if it doesn't drop, I consider that pretty good. But if it drops, that's when people, you're bent over doing something, you stand up, and it's like, whoa. We've all probably experienced that at different times. Especially if you've ever noticed, maybe after a hard workout, maybe the day before you had a super hard workout, or maybe you did a bunch of extra work or stress or not enough sleep, then there'll be a day or two where you'll be doing stuff and you change positions and you get all woozy. That's orthostatic hypotension. And it can kind of wax and wane in younger people depending on how much you stressed your systems. But as people get older, a lot of times it becomes kind of an ongoing issue. And it often can be helped dramatically with fixing their adrenals, which means fixing their diet. Anyway, so if you guys, I'm sure know this too, if blood pressure goes up when a person lays down, it's considered a kidney problem. Something is up with the kidney. Anyway, aldosterone, we talked about this, that's one of, I think it's the, is it lisinopril? One that, ACE inhibitors, I think, interfere with function of aldosterone. Aldosterone's job is to make sure you don't get rid of all your water. It's to make sure we keep, it's the recycling hormone for keeping water in our system. So, anyway, this is kind of a, you guys, this is kind of the general category. I see these every day. And it's like, oh, I can almost, when somebody gets diagnosed with AFib, I can almost guess what they're going to come in on next time. And usually they're using a lot of beta blockers for. These are standard process nutrients that are good for kidney related issues. Blood pressure, I've never done this much, but you can TL the carotid and supposedly use it to TL for cardiovascular health, and you can cross TL to liver, cross TL to adrenals, thyroid. So anyway, I always think with any kind of blood pressure issue, I'm usually thinking detox. Usually people, you have to start talking to them about getting detox in, because a lot of times they're also constipated, they also have livers that are probably pretty congested. If they're really serious about dealing with their blood pressure naturally, they've got to clean up. Got to start. They've got to start making some major changes. These are homeopathy things that Dr. Francis used a lot. This is one of his. You guys are all trained in homeopathy. You recognize these. I don't use much homeopathy. I will test it. I love testing it. People bring it in. They have their arsenal of things. A lot of times people come in, they'll bring everything they're getting from their naturopath or their whoever, and then I will test them, and it's really fun because a lot of times I don't even know what's being prescribed for, so I'm just kind of blindly testing. But homeopathy tests really well energetically. It really does. It's fun to work with because it's so. These are things I use a lot. These two I use a lot from biotics. These are standard process. I thought that was Thorn, but I think that is standard. This used to be all the big talk here a few years back. I don't hear much about homocysteine now. Like it was a big deal in kind of the nutritional world. I used to have homocysteine vials. I don't know if I still have them that I can test with. Nitric oxide, that's one of the reasons I love having people learn how to breathe and learn how to do yoga breathing, especially nasal breathing, in and out through the nasal passages. It really helps build nitric oxide. Helps calm and that's why one of the reasons it's believed that deep breathing, rhythmic breathing creates more parasympathetic activity in the body, which we've known for eons, but it's biochemical mechanism now that's recognized. But this was an interesting slide. This guy is kind of one of those Brett Gurus, I forget his name. He's quite popular on. Allergies. These are basic concepts about allergies, and you guys understand this. The allergy, we blame the allergens, but really sometimes we react differently. I have allergies in spring, and I have allergies in June to grasses where I live. But if I'm eating well, my allergies are pretty minimal. If I'm not eating well, my allergies start to get to be a little pain. If I'm eating too much sugar, yeah. So there's a direct link there. Tolerate allergens until we don't. Like any other toxin, we tolerate toxins until we don't. So we've run out of room to hide them. Fine. So this is something I learned years ago. I started having really good results with some of my allergy patients getting their stomachs working better and getting them on things like Hyperzyme and HCl plus or Zypan. I used to use lots of Zypan, which is like sort of standard. And you know, it would improve their digestion. Usually, that was my goal. But often they would really see an improvement in their allergy symptoms. So that was interesting. And then I got to talking to a lot of other functional medicine people, and that, you know, yeah. So if you think about it, your stomach is, as far as what we eat and drink, the stomach is one of our first lines of defense against all kinds of bugs. Because when we eat, we're eating all kinds of bugs. There's all kinds of nasty stuff. If that food sat out for any amount of time at all, funguses, there's bacteria. And if our stomach acid is working well, that stuff doesn't stand a chance. Those bugs just like if your stomach acid is working really well, you can eat gluten and the gliadin, which normally kind of floats on down and gets the immune system all up in arms. The gliadin will break down like any other peptide. Now you've just got amino acids floating down into the small intestine. The immune system doesn't have a problem with those. It does have a problem when those amino acids are shaped into some weird thing like casein, like milk, cow's milk, casein, or gliadin. So to me, it's like stomach function, hydrochloric acid production is so essential to all. And often it's kind of overlooked. They kind of bypass that. And so many people are being treated for indigestion with antacids, which are interfering with the very system that needs support. It's actually holding back mechanisms that should be supported and production of HCl. But then along with that, you've got the whole stress patterns that people are going through, the elevated cortisol, the sympathetic drive. They're stuck in for weeks, months, years. So all that is what's led to their inability to produce proper amounts of stomach acid. And that also interferes with, we talked, I think last time or time before, talking about iodine. Iodine is one of those things that's really important for the maintenance of proper mucoid layers in the gut. And that's where all these microbiome are like doing their thing, and there needs to be this kind of nice protective goo in between them and the cell, the actual cells. Quality of that goo is important, and iodine is an important component of that because it's what's necessary for the body to make mucinase. Keep the mucus so it's a certain consistency. So all of that ties together. A lot of people are iodine deficient, I think. A lot of people are zinc deficient, so that also contributes to HCl or production. And then they're under stress. So they're getting poor gallbladder function because they're getting weak acid production in the stomach. That creates a whole other pathway problem. We didn't talk about deep tendon reflex. Did I brushed over that? Were you? Yeah. Okay. That Dr. Belli, just was our recent ICAK president. He developed that technique years ago, and he found it to be sometimes a good way to lead to ferreting out allergies. So epinephrine, very important. We need it all the time. If I was to run up a flight of stairs, my body would need to squirt a little epinephrine. Otherwise, I would collapse. My blood pressure would drop. My respiration wouldn't meet the demands, and I wouldn't make it. And it's not long term. Epinephrine is supposed to get you kind of up the stairs. Well, then the cortisol kicks in, and anyway, your blood sugar comes up, your energy metabolism kicks up, and then that sustains that increased functionality. But the initial thing that keeps you from collapsing on the way to that is epinephrine. So this is probably old hat to some of you guys, but this slide that's the one I got, yeah. This slide is nice because it kind of shows you when you're testing nutrients with renal problems, you can just kind of see everywhere you go, B3, then you got B5, there should be B6 there somewhere. Zinc, of course. Everywhere you turn, of course, E. So if you want to test individual nutrients against, say, a Chapman reflex or an endocrine-related muscle, you can go to the slide and you can just grab those vitamins, and depending on if B3 strengthens them, then what you go with. Maybe zinc's the only thing that would strengthen. That's what you go with. So anyway, anatomy to consider. So when you've got allergies, you've got, especially food allergies, you've got weak links at every stage here. So if you've got jaw problems, you're not going to chew long enough or chew thoroughly enough, which is a problem. If your esophagus is sucked up because of tension or irritation, you're not going to swallow well. And stomach, hydrochloric acid. Of course, duodenum, you need that blast of bile and pancreatic enzymes. Of course, the liver deals with everything, right? So all of these things can potentially be found and then treated. ICV, I mean, honestly, if you check ICV in stomach on everybody, you'll find it on half of them, at least. And on half of those, it'll be a significant contributor to whatever's going on. And that's kind of a generalization. You want to learn, if you're learning visceral manipulation, learn stomach and ICV. The rest is all fun and helpful, but those are the big tickets. Zinc, we should have brought, any of you familiar with the zinc taste test? Called the zinc tally test. Yeah? Everybody, yeah. Do you guys use that? How do you guys determine if someone's zinc deficient?
We basically don't unless they're sick or they need it like something else, but we just basically do it. Well, from the doc's side.
Because it's the only way I know that you can really, and I think it's a very reliable test, very old test, and it's probably considered very low tech. But if they take a little bit, less than an ounce even of zinc solution in their mouth, and if it doesn't taste like anything, they're zinc deficient. And if they're okay, it'll taste pretty nasty.
Everyone gets too scared about the zinc copper ratio, so if you recommend zinc, they're like, ah. I'm like, why? It's indicated.
I know.
I've had a whole bit.
Anyways, well, it's just like the iodine thing. I mean, yeah, it's tricky. There's some really well-held beliefs that I think maybe aren't accurate. So anyway, these are the things to look at with allergies with regards to the stomach. I think with the liver, these are things to consider, of course. Small intestine. I wish I would have brought my ICD. These are, a few years ago, SIBO was a big term, right? Everybody had SIBO, and small intestine bacterial overgrowth, and most of the people that had SIBO had ICD. I mean, basically, if the ICD stuck open, you're going to have the wrong bacteria in the wrong place. And but then it became this treatable condition, and nobody was looking at ICDs, considering that as part of the cause. They were just treating this bacterial overgrowth, and they were killing a lot of bugs off. Some of these protocols were really harsh that patients were on. Anyway, so ICV, remember, ICV C501. I'm surprised there was one question on ICV on the manipulation. It's down and like to open an ICV, you go down and in. Close an ICV, you go up and in. Closed up. If it's stuck open, you want to close it. If it's stuck closed, you want to open it.
I read that and understood it, but still probably switched that.
Be another one with you guys. So I think a number of people missed that, and I was kind of surprised.
I think my brain was like, nope.
What's that?
With an open ICV, what kind of food are they supposed
Popcorn, nuts, seeds, chips, spicy foods, chocolate, alcohol, caffeine,
Between roughage.
roughage, yeah. Popcorn, chips, that cover. I mean, it's things that are scratchy. What's that? What's that?
Overcooked food was not it.
That one threw me.
That must have been.
No, I think I put roughage, but like.
Was that on
option.
the L exam? Yeah. I don't. Yeah. Anyway, popcorn. Yes.
Did you say, you said when it's open, we're pushing up or we're pushing down? Sorry, can you say that again?
It's over there. If you're
Okay,
on your
sorry.
yeah. Unless you have retroversion of your organs, and I've had a couple patients that knew they had that, and their ICV could be clear.
Can you repeat that though, where you're pushing up?
So,
first, or-
if it is, okay, say first you got an ICV, you got something, it's a positive TL, just to kind of go overboard. So you got a positive TL, and that will usually strengthen. Like say you're testing iliacus or glute or TFL or any number of things, hamstrings even, because they're related to the large intestine. And you're getting all these funky weak muscles. Well, then you have them hit this. Maybe you have them take a breath in. You maybe have them TL right at the nerve supply, and then you have them TL the ICV, and a lot of times these muscles will turn on, and you know you've got a positive TL. Then you go to a strong indicator muscle, maybe whatever it might be, maybe a PMS, because you kind of test it there, and then you have the patient. Usually, it's good if you have the patient TL and then take their hand and kind of push it up towards the opposite shoulder. So at first you put their hand on, weak muscle, weak, strong indicator muscle, strong, weak muscle, right? So far you've had this the TL strengthen weak muscle, and now it's going to weaken the strong muscle. Once you find that, you push in and up towards the opposite shoulder, the muscle should re-strengthen. If it doesn't, you push down and in towards the pelvis, and the muscle stays weak. That means it doesn't want to go that way. It wants to go this way. That means it's closed. It's open, and you need to close it.
Right.
So to close it, just think closed up. Or closed up. Push in and up towards the opposite shoulder. Now, if it tests like it needs to open, then you push down and in towards that. And that's less common. The open is more common than the closed. I mean, it's always good to go over that.
Just so if you have to open it and push it down and in.
Down and in. Opposite way of, yeah. If you visualize where the cecum is the bottom, the beginning of the colon pouch area with the appendix and all that. You visualize that kind of coming up, and then you visualize this little tube coming here from the small intestine, and the valve is sitting there like this. And if it's open like this, it usually means it's kind of like that. It's kind of, maybe you've got lack of abdominal tone. It's sort of hypotonic in your gut. It could be stressed in the rest of your body, but your guts are like, they're getting lots of inhibitory signals. So this valve is kind of, and goop is kind of going back and forth where it shouldn't be. That's an open. You need to push up, and when you do that, it pushes right on that valve and stimulates that sphincter. Wake up and start clamping down. And it also flushes the goop that's sort of preventing that sphincter from closing. That's what you're doing. If it's closed, you'll have a buildup behind it in the small intestine. You want to come in such a way that it will stretch open, allow that stuff to kind of go, so the small intestine takes the pressure off the small intestine. Super fun to fix. Started on emotions a little bit. I'm not sure this is true, but this slide says it is. 85% of emotional problems are physiological. I think probably maybe all emotional problems have some physiological counterpart, either coming from the emotional problem or maybe added to it, or blood sugar certainly. I have known people who their thyroid was the primary cause of their depression, and when they finally got their thyroid working better, it was pretty amazing. I have a cousin who, for years, she had a lot of issues with thyroid and a number of things, and she found out she had the MTHFR gene a few years ago. And she had like the full, I guess you could have different SNPs, right? She had like the full menu. And so she went on the right nutrients. It was game changing for her. Absolutely. She felt better than she had in her entire adult life. And she continues to, she's doing better. So anyway, emotions, of course, over there on the right side of the triangle. A few of you guys missed these. There was a question about Bennett points, about neurovascular points being Bennett points. And a few people missed that, so we'll have to go over that one too. Remember, these points are also the ones that are related to the stomach, gallbladder, and the bladder.
You said stomach and body?
Stomach, bladder, and gallbladder are at these points. Liver points are just above there. Stomach, bladder, and gallbladder are right. And then, of course, that's the one we use for I mean, are there other points? I do use this point on right at the hairline. And I'm not sure where I learned it. I might have made it up. I don't know. But I use that for processing. Like if someone is, maybe it's not emotion so much in the classical sense. it's more of their processing mechanism is kind of overworked. Anyway, so when this is something you can do with, if, especially people that had trauma, car wrecks, things like that. You can get them all adjusted and then have them go and have everything, all your indicators are, turning on and whatnot. And then have them visualize the injury again. A lot of times those same areas will go weak. And a lot of times you can use D&E points like we talked about yesterday. You can use these holding points like they use in NET while they process and think about the trigger that came up to them. It's kind of a simple, straightforward way of doing it. It's not as detailed as T. Really chases down the individual triggers. Psychological reversal is another technique where you have someone say something like, my name is Joe, my name is Dave. It's Joe. That's a way you can test people. And it's kind of a way to I do that with people if they're not familiar with this and I'm doing some testing. I'll do some kind of fun things like that. And then have them say things like, I'm a good person. I deserve to be here. Whatever you can think of, whatever might relate to the matter at hand. And if they weaken to something that they shouldn't weaken, like I'm a good person, weaken to that, well, maybe they aren't a good person. But what that tells you is that they don't believe them. Maybe they are. But if they aren't a good person, they usually don't weaken to that. But I'm a good person. Used to lying. But some people this works on really well. Some people are tough. Be careful. Be careful. Here's some of these are fine. Totally, completely accept myself with all my. Get well, stay well. I can pass the exam. I know I'm going to graduate. And a lot of times people will weaken it. Now, what I do usually is I'll use the D&E points. Get someone yesterday and say, I really love myself. And then you go to the different D&E. And then one of them will negate that weakness. Whatever it might say, it's stomach. And then you start looking at other things that have to do with the stomach. Or you can tap that point if you stay right there while they say it over and over again. And then you retest. So yeah, this is talking about. This is really fun to do, and it's simple. These are the D&E points. And oh, good, I did have this slide. These are the neurotransmitters that Dr. Wally would consider if they kept coming up with, say, a bladder point. He might then test them for serotonin precursors. Because he did a lot of really elaborate nutrition testing. Epinephrine, acetylcholine, norepinephrine, and GABA for large intestine. GABA is the only main neurotransmitter that's inhibitory primarily. All the others are stimulating. And when our GABA is in short supply, we don't have enough of a brake on our brain activity. Valium. So Valium is a GABA agonist. Phobias, I don't really do these, but phobias, I'll use if I'm going to do something like, okay without sugar, you're okay with heights or something like that, I'll use the temporal side. Positive statement there, and then you can go on the other side. I think we brushed on this in one of them. And you can use a negative statement here, like I'm letting go of my fear of heights, reason to fearful heights, so on and so forth. Or person or boss or any of them. A lot of times when people go through trauma in car accidents, they're scared to death to get back. A lot of them just kind of override it and just buck up, but they're the worst ones because they get right back on the horse and they're driving, but they're freaked every time they see somebody, something that might trigger their memory of the accident. And they're way more tense. And these, a lot of times when people have, maybe they weren't really injured so much in the accident, but they have this really traumatic emotional event that really stays with them. Then kind of way down the line, a lot of times I'll see these people in the accident was 6 months ago, yeah, I thought it was fine, but I just haven't been right ever since then. I wasn't really injured, and the doctor said I was fine. And a lot of times they have some of these complexes going on. You start asking about what else has changed. Well, you know, I kind of quit exercising after, or I kind of fell off my diet, or whatever. There's something else that might have transpired, and now they're not living optimally, and they're not experiencing life optimally. They don't know why. A lot of times it's because they are scared to death of being out there on the road. It takes a while for that to wear off, and sometimes it doesn't. My mother, not to share too much, many years ago, my mother was killed in a car. I was 22, and it was one of these things where she was going down kind of a 2-lane highway out in the country, and another car just brought us at full speed. Didn't stop, supposed to be a stop sign, and she died instantly. So she was alive one day, and the next moment she was gone. It was all from the intersection. So for years, to this day, I am super cautious, especially on old country roads where you're kind of running down, kind of think there's nobody around. And if I see a car coming that way, I still get a little jolt of things. Slow down. And because that's how she went out. Didn't even see it coming. So I eventually got some work done on that. And which was and still very cautious at the intersections. Anyway, so B&E points, tapping. Once you bring up the thing, the fear, the phobia, whatever it might be, the psychological switching, the psychological reversal, bring up the thing, get it up on the screen, and then you can start tapping these points. It'll kind of help dissipate it. It's kind of like IRT, where you bring up the past trauma in the tissue. It's in there. It's got that neurological sort of pattern entanglement in there. You bring that up on the screen, and then you do the ankle flick, which sends a jolt of afferent input into the brain, and it dissipates. That's the way I think. That's the way I describe it to patients, if they really want to know. Often they do. What does that do? So, anyway, all the different things to consider with depression. It's a vicious cycle of immune system, endocrine system, nervous system. This is just for your own quick reference. These are the main neurotransmitters. Remember the whole problem with GABA. GABA is produced on the same pathway as glutamate. Glutamate is very stimulating. Make us pretty wound up. I can't remember the exact mechanism, but like refined carbohydrates can interfere with the conversion from glutamate into GABA. So not only can sugar make you more hyper, it can interrupt the production of the very thing that keeps you from being. So it's another shot through that in there. So these are the main food sensitivities, i.e. allergies, I tested before. I kind of keep it simple because this is basically in America. This is what everybody eats, pretty much. I mean, I Nightshades are kind of interesting because they're probably the least talked about. You know, a lot of people know they're corn sensitive because corn, a lot of times you'll see less skin issues. People are corn sensitive. But and of course, we got issues with all of them. But nightshades are weird. They can be like brain fog, arthritic pain. Getting people off nightshades, you never know what you're going to get. Sometimes it's really rewarding. Sometimes they don't feel any different. Gluten, of course, the big thing with gluten is a lot of times gut issues, brain fog, blood sugar instability. They're always gassy and poopy. And mood swings. It's like, I say this, I'm weak intolerant, and that's how I was for years before I left out. It was killing me. Years ago, I got tested and I went off weed. It was like somebody gave me some kind of miracle drug that just fixed everything. And for years now, I haven't been on it. Once in a while, I'll get a bite here or there. But the symptoms that I had, I haven't had them in years. I just forgot what it was like. So, I don't know where I'd be if I stayed on. I don't know where I'd be. Probably not very excited. Or maybe I'd overcome it eventually. So this was your schizophrenia thing. One of the test questions. I don't know. I tried to find, this is a slide, this is where Dr. Brandon's slide. I tried to find this and it didn't take me anywhere. There's some tests for schizophrenia. I don't treat schizophrenics. And I have treated them, and but they're heavily medicated. Huh?
I was just asking that. So they're not medicated, and would it be coming to them?
Yeah, no, I don't have a lot of them, but I have had a few. What's interesting, I've got two patients right now. They're both men in their later 30s, really interesting young men, totally unrelated. They're epileptic. And boy, they've been through it. And I've been treating them off and on this last, I don't know, 6-8 months. That's been interesting. Well, the one guy, one guy, I just saw him last week. He has a device implanted that it's a vagal nerve stimulator, which has been a life changer for him. It really helps. But when the thing goes off, it triggers these muscles and it throws his neck and his teeth. So he calls up and he's in right away because he had a seizure and and I'm usually able to fix him. I get his jaw. I've really helped him a lot. He has been a lot better since I've been at HC. And all I've done is reset his TMJ and adjust his upper shirt. That's all I've done. I haven't done anything else. No emotional work, no visceral work. Maybe his ICD. I might have fixed it. But anyway, and he's just, it's really helping.
Did it affect the seizures?
What's that?
Did it affect the?
He thinks it has caused them to space out more. He still gets them pretty regularly, but he feels like they're spacing out longer, and he's better in between. But I can tell I've probably seen 4 times, so, and I can really tell a difference as to what he comes in. When he first came in, and I wasn't sure if I could help him at all, because I've had other folks with epilepsy that. The other guy I've been recently treating, whole different thing. His seizures are more kind of like what do they call this? Catatonic seizures. He doesn't like, he's more just, and I haven't helped that at all, but I have helped his low back, which is one of his chronic issues. His low back is really, really a problem. Yeah, anyway, it's interesting what you attract. MS, there was some years back, it seemed like I had like 4 or 5 MS patients. We're all in varying stages of degree. What's that? Oh, I have. Yeah, I've done on this gentleman with the jaw. I do his TMJ, cruciate. I've done his phenobasilar. I think I've done a temporal bulge. You can kind of take your pick. He's got all of them. But I get his atlas and his occiput all just kind of lined up, and that I think makes as much difference. That's really there's 7 times the mechanoreceptors in the upper cervicals as the rest of the spine. So, anyway, I don't want to dwell on this too much. You guys, I'm sure, get plenty of ways to scan for schizophrenics. I just threw this up here because I was doing some reading here a while back, and just was kind of surprised. NPV, which gets a little more press these days for various reasons. 1 in 200 people. That's a few, right? And sociopathic, psychopathic, which there are distinctions, but a lot of the things you read kind of lumps those together. I think psychopathic is like sociopathic, only worse. I don't know. 1 in 100. Now, I know probably several thousand people. So, and I know several that I would consider sociopathic. And borderline personality disorder, I know quite a few of those. In fact, I might even have some of those. Depression, 13, should be a period, 13.1%. I don't know what, that's a mystery. I must have done that too late in the evening. 49,000 deaths by suicide per year in the U.S. I have had patients that have committed suicide. I've known people that have committed suicide. We probably all have. If you don't, you will. It's just shocking. 17 to 18 veterans die by suicide. That is just now. I just read that the other day. That's shocking. And that is, I can't even get my head around that. I double checked that several times. It sounded so outrageous. Several sources had that. Anyway, so treatment basics. I'd love to maybe go through a few people and maybe talk about flow, bring some of this stuff together. Should we take a little break for? Let's hopefully we'll show up. Ah, 10 minutes off. So she's 9:41. Oh no. C3. Sorry, I should have. No, but C3L3. Remember, that's the beloved brothers that you see in ICD. C501. So C3L3 was Dr. Goodhart seemed to find that was what would negate the effect of disruption, which was often thought to be related. Allergies check ICV. But with allergies, check ICV and check stomach. Check. It's like a manifestation of the allergic disruption that the allergy causes. And it's like a manifestation system. Well, C3, yeah, that's on the slide.
So if you adjust C3, does eligible automatically? It doesn't, yeah.
I know there's a question on that, yeah. No.
Because I was like, it could, but
I
it
know.
doesn't. It's
could,
not gonna always.
If you just one, then check the other, see if it's out, and if it's out, yeah.
And then a lot of the cases.
Well, there were several questions and several people asked, said, this says always. Nothing's ever always ever. And
That was the one
in the world of, yeah,
in the world of AK,
in the world of the human body, there's no such thing as ever.
Nutrition books. It's almost nutrition like halfway learn because I think some of the older nutrition learn is actually probably more accurate, just not taught.
Ours is so muddled now with all these.
Everything has to be based on some study.
And it's just that I asked a few of my doctors about it. I said, and they would pay by, notes to put out and stuff like that, and they're like, oh, no, that isn't. I mean, me, that doesn't matter. There's a lot of what we get taught that I think paid.
Well, the stuff I got taught in chiropractic was pretty extreme. Like, it probably wasn't different than hospital. Pretty worthless.
Oh, I like all the stuff that's on the.
It's totally, but that's all AK was really kind of part of how it's developed into fitness. And now you've got, it's one, I think AK has had a big contribution to now become the field. Functional medicine before there was a name. But people like Waller were real pioneers. He was able to teach how these, before it's like, well, this nutrient is good for that. There was
That's okay.
so
Yes.
that he could kind of make it read.
Yes, it's, thank you.
Oh, you read the old Western Price?
I thought of it when I got home last night. I was
I
like,
know.
dang.
I guess.
Western Price. They're the early nutrition.
Thank you.
Try reading that and see what you can see. If there's a fracture, you can't really see it. You can see it on one.
Yeah, I'll take some pictures and send them to you.
And he started
Nutrition.
So you said Western.
Yeah,
What?
Weston Price.
Or what is it?
Nutrition stuff?
Oh, okay.
check out the Western Price. No, I think it's called the Price Pottinger Foundation. Another doc was Pottinger. He was also. So some of the great early nutritionists of like the 20s and 30s that started writing all this stuff and discovering all these correlations. Because they were the first ones to notice the effects of a couple decades of resistance. By the 20s, you had a couple of decades processed foods, and people were moving off farms and on cities, and their nutrition was going down the tube. And they were the first ones to notice
Seed oil free,
changes in
no
the
refined
house.
sugars, everything's made from scratch, and they use only
And
local,
some of that early stuff was brilliant. They were brilliant people.
So that
They were
was just our outcome.
Renaissance thinkers of the time. They were largely ignored. Royal Lee was
I did it, and then.
his
So
entire profession.
this is just
You know,
to get it to
he,
you. I'm gonna give this to Don.
Okay.
And then he's sending it to you. Everything that's
And then,
on papers.
is there a pituitary? I know this is like a brain, but is there like a pituitary Or do you do more sort of like extreme hormones?
Medium gray short ribs, delicious.
Delicious.
Oh my god, I was.
There is a pituitary,
I'm
like you can
manifesting.
go to
I
the
was like,
novella.
Exactly, so that's why when he
That's
was like,
basically,
yeah, think about like when you're graduating, and I was like,
you can
that's sooner
access
than I
the
realized.
You
TL.
got
We're-
tummy therapy.
Well, I'm curious if
I
there's,
don't really use that one.
I know it's like the basic level one, but like if there's
And you could
some
also
sort of
say that, you know, you come up here underneath the cruciate, you're just hair above.
You mean like just like
Just
just more?
like just income pretty much, since you have that.
It sits right there.
It was just that, like wall over. You know what I mean?
Kinda. Do you mean like
Actually, it's
learning
there.
more
It's got the
stuff,
pineal.
or just like as far as like utilizing it?
Utilizing it, yeah. Curious,
Um,
because I know like.
as
some-
far as like
Pituitary, hypothalamus.
Yeah, either in clinic
Pituitary is
or
where
like
the
there was
mind and
a
body meet.
ND that Josh had that graduated from here and through
Interface.
school, she did some.
I was curious, I do
Like
think I
actual work and she like she like did online consults like while she was in school, but just on her certification.
oh, see, I didn't know that. That's why I was like, what do you mean?
Yeah, yeah, she was like actually extra money like working for her.
Do you know like who she did that?
She said she did like online like consults for like
There's,
I think
yeah,
it was
try
like
it. You know, always try it and then, you know,
it
check
was
other
kind of
ways.
like testing, like condition testing,
Yeah.
but she was able to have
I didn't know we could do that though. Do you know what I mean?
yeah, no, I don't either. When I Josh had her, she said that she did
My
it while she was
analytics.
going there. I was like, I thought we,
I mean, I could.
because it wasn't under her.
It probably
license,
makes no
so she
sense at all,
wasn't saying
but-
she was licensed, she was
Yeah.
just like, I
Oh,
did this
cool, cool, cool.
certification.
That's half the
And so
battle.
like she
It
was
looks
able
like,
to
wow,
kind of work while she was
look
in
at
school.
this.
Yeah.
You don't
I
believe
guess I was just, it used to be
That's
misconceived.
That's the proof right there.
I was under the impression that like
Look
we
at
could
this.
just use it until we were like.
Now tell me.
Yeah.
Yeah.
Most of the stuff we learned,
Oh, that's beautiful.
but like nothing that like we learned
Okay,
for
so,
certification.
It's just like a
what I would,
Yeah, like let's say you went outside of here and got a certification in Reiki, like you could practice Reiki, like you know what I mean?
No, that's just so funny for me to like add up right now because I
Yeah.
want to get certified in EDT. So I was like, is that me?
Yeah, you can
You
practice
can
That
do
I
it.
can literally.
Like
what's that?
start some sort of online thing.
Bless you.
I don't, yeah.
So.
I didn't know how she did it because she was like energetically connected with her
Yeah.
patients and
Yeah.
everything.
Yeah, see, I wouldn't be able to do it online.
Yeah.
Well, we were talking about like before, because she said that the person that she shadowed, they were like doing that and getting paid for it like while they were still in school.
Certifications they have, just not like stuff we learn here. Yeah.
I would say I know we could do that.
Oh, yeah, anything you're training, you can do this.
Okay.
Can't say you're a doctor.
Morning.
Well, that's what I was thinking about, because the girl, like I was telling her, the girl I dropped out, she did like some energetic type healing, but I didn't like necessarily how she did it, because she was connecting like online and
Yeah, I feel
don't
like that's kind
understand
of
how
weird.
that works, like I don't know how to energetically connect to patients through the screen, but.
So that's like being like, I'm gonna do
Migraine.
healing people over.
Right, like
How
that
do you
doesn't
even do that?
that doesn't make sense to me, but she would literally like online, I got her, obviously I'm now, but she was like testing them for like food sensitivity. I don't know, but she said like, it was accurate, I was like,
Maybe she's just like that still.
she did seem very like
Pretty analytical.
That's the only thing, like, the only way that I feel like that's possible.
well, I think she also did she was working out she didn't do a lot, like she prescribed and not prescribing right, so I think most of her practice was built on like energetic.
Yeah.
Okay.
So it was really cool.
Well, I feel, I mean, I do people that like get like, people that they have to feel like it's just like I've tried it, and I don't even know what to do.
Yeah,
It's hard.
it takes a lot of like, I asked her, I'm like, does
Are you like judging me for my test? Or you?
no,
I didn't judge anybody.
I'm joking. I know you're not judgmental.
I'm not a judgmental person.
I know, that's why it's just
Not to my friends anyway.
Not
Not to my friends.
No.
Everybody else I'm pretty judgmental.
I think that's where the confusion is.
Yeah.
Like, I know it's there.
You don't know which side of the line you're on.
Yeah.
No, you guys are all on the good side.
Sorry to be
oh no,
Do you have a,
Yeah, Yes, but I don't know when he's
Well,
doing
they
it.
were telling me that, but I had no idea.
I think he was waiting on me. I was late. My bad.
Yeah. He was like, here's what you
No,
work
she's
for. I was
coming.
like,
She's coming. I was so I feel like that's got enough, but we are here.
yeah. It's a good idea.
Oh. Please.
But, you know, there is a yarn store in
It's a full closet. Yeah, oh, thank you. I don't really own color. I'm working on it. Trying. But it's ongoing.
Erin, can you make sure it's all correct? Did you finish it? I did. Okay. Yes, you did. Make sure you sign it. There's a lot going on in here. Mailing address. This is where I need to add in like. I'm gonna give this to you. Right there. Figure out the. Large. Yeah. Yeah, I was thinking Jenny's sweater by the time it gets cold. I want to make one. My cup is tilted. Oh my gosh, the thick ones. Why does everyone else do so much? They're not hard to do.
Yeah.
Yeah, you can do it.
It's a single crochet, but
Because everyone's got like long.
I learned.
Let's just do this. I
was in a. I always try to learn.
And then the rest of the next
Like you're either really good at crocheting and trouble with any or vice versa. Which I was weird. Yeah, like you really it is. But I think good. I did have a scarf for my first project. And then a hat. And now I was doing this 100% all kinds of weird. So I think it's not much. I don't know. You can just see that.
Anyway, we're going to talk about.
Yeah, that's good. Thanks.
Is that the one you want? Certification.
Where'd everybody go?
Thanks.
I got to see.
Oh, his sister, my friend has a sister, both of these, and oh, you want to come say hi? Not everyone just come say hi. Oh, if you want.
8L.
Yeah, no, he literally.
I didn't look at my zip code. Maybe I should. I think so. Where am I? 225. Okay, no, that's right. Yeah, I just want to make sure. Thank you.
I'm sorry.
Oh, that's.
Oh, that's. Wait, are we gonna look at it? I have to take it home to look at it.
Some pics.
Yeah.
Some pics didn't happen.
Yeah, no, that's how I'm gonna show her because it's not like she's gonna come to my house and look at it. These, are you?
No. My problem is that I literally was like, I was at
Yeah, you did.
yeah. So I got up there and I was like, I'll go to Aluma and get coffee. And then I
Oh, is that where you're getting coffee?
I didn't leave until it was 12. And I was like, I just said we were going to do it. It took me 12 minutes to get there. And I was like, I'll just go squeeze. There's something making it.
Yeah, that's the only thing about like getting coffee home. It's like, am I gonna be disappointed?
I can't get it home the way I want. So I'm going to either you go by yourself or because
I just want to make sure.
Where is it? I've been like through. I like vaguely know where it is. Yeah.
yeah, so it's in that little it's constantly and then I see this and then I do the other tea ice and it's a lot like
I mean, compared to some places, no, $6 is not a lot, especially depending on.
my used to be because like even at times the ones the shakers they're really $5.
I love that.
I was like, honestly, you could get a little bit.
Well, honestly, it's something about, I don't know what type of milk the coffee shops are doing, but like if I get like grass-fed milk, like grass-fed cow or raw milk from the store, or like freaking farm, like I can drink that, but it's something about when I get milk from a coffee shop, I tear it. Like I can't.
I had it one time. I didn't ask for it. They just rinsed it up, and it wasn't even as bad. And the TC I was drinking like 2% sugar.
Oh, see, I can't do 2% either.
It was 2%.
I actually either way, I think I have terrible stuff. I get terrible stuff.
It has oat, unfortunately, with that.
Yeah.
And then
Oh, that should be okay.
Yeah, we should go.
cinnamon, which is pure cinnamon.
Oh, okay. That is good.
And now I'm trying from sexy trying cinnamon.
Probably,
And Arena has a really good one. But it was too far, so I didn't get it to do.
That's to make that coffee at home. People, the coffee shop so upset because a lot of times when I get like almond milk, it just tastes weird.
So can we, I'll hand all of them out? Is that okay?
I don't know. If they marked it with a lot of like ugly things, I'm gonna
It's like
secretly
you can
cry.
look at mine. I'm just gonna laugh. It's fine. I'm
Don't
sorry.
giggle and come over here.
I did
I'm
this
just a
in-
smile. Come on. I can be
My
rude if you want me to.
No, I prefer this. I'm sorry.
Mine is since I'm studying for boards.
Oh, there's no
so.
answer.
You're doing great.
Huh?
What are you talking about?
Stop, don't look.
Well, mine's on the
They are. Your answers are on there, Buster.
Buster.
That's my entire life.
I was like, what?
Tell me what the program is.
I know, that's why I was like, oh, it's so small. I didn't even see it.
React if I would like to. That's a good point. That's a really good
That's a good point. Oh wait, no, mine aren't on here. She didn't put.
You can look at mine.
No.
No, I think you can look at mine.
No, she put like X's on the ones that you got wrong. I
Yeah,
didn't
but
put
it's corrected.
I wrote it. No. I'm so confused. Oh, maybe.
Yeah, that's
Oh, maybe
what I
I'm
thought.
confused because our pen colors look the same.
I did pencil. I switched it. I knew it. What up? So I changed it last minute. Fucking did.
Oh, I see. Okay.
I knew it. Why did I change it? Don't ever raise a freaking fuss.
No, literally, don't do that.
I just calm down.
Yeah, calm down, fine.
Everybody's got theirs then.
This is hilarious. That one did not.
So,
What'd you put for 40? I don't know, I'm trying to.
5 element analysis.
Oh no, I got that wrong for sure.
Can we make that make sense?
Yeah, that's. Oh,
I also, yeah, this one I read wrong. I was right. I read it wrong.
38.
Which thing should we think is wrong?
no.
Oh yeah, I got switched.
Didn't hope, yeah.
Okay, so who has the M test? M testers. Okay, all right. And then everybody else has the L, obviously. So I
It's fine.
No, it's fine.
so on the M test,
I changed so many last minute.
and I don't. Okay, so on the M test, and we'll get to the L test too. The first one that I had marked that was kind of problematic. The very first question was on feet, and the correct answer was okay. So the question was which muscle pattern is characteristic of hammer toes, and we didn't talk about that a few times. And I think maybe I was talking about hallucis, longus, and brevis, longest, strong, or brevis weak. And the correct answer is a flexor digitorum brevis weak, flexor digitorum longus strong. And a lot of folks miss that, and I kind of feel like maybe I wasn't clear on that. But does everybody understand that now? Yeah.
What else is that?
It's number one, the very first one. Did you get it right? I can't remember.
Yeah.
You got it right?
Yeah, I got it.
Okay, okay. So, I mean, I don't know, some of you didn't get it right. I want to make sure that you know that it's the flexor digitorum brevis loses its innervation partially, and it can't fire, but then the longest comes through and it's attached distally on the toes. So when they contract, there's nothing to manage the proximal digits, the proximal segments of the toes. That's what causes the hammer toes. So down the line, no matter what, remember that. If you got it right, you already know it. But so another one that, and I'm going to go through the ones that I found problems. One of them was number 19 on the M exam. I think I took this one out of the race because the correct answer is the patient's energy metabolism should be investigated. The question is, the patient's weak muscle strengthens after rebreathing his own air. You conclude the correct answer is the patient's energy metabolism should be investigated. And a lot of you did get that right, but honestly, we didn't really go over that. And so I felt it was probably fair to throw that one out if you missed it. So anybody have questions on that one? Anybody get that one right? You did? Okay, number 24. This one was confusing, and I cut this one out because we really just didn't go over this well enough. And it is confusing at its best, this particular technique. So if you got it wrong, which most people got it wrong, I think the ones that got it right probably just guessed right, because I really didn't go over it thoroughly. So that one is a 5. Number 30. 24.
What was it?
What's that? Phylum terminal, coccygeal lift.
Patient challenge. Okay.
It's the patient challenges the coccyx forward.
Okay.
That's the correct answer. I mean, it's confusing the way it's asked too, but it's intended to be you know, challenging, I guess. Okay, so number 30 on the M test. The left brachioradialis tests strong, but weakens upon cervical compression. Which adjustment is most likely to help? This one was very, I think, most people missed it. The correct answer is C, A to P and inferior on left of C6. Now, it's a little tricky because, you know, but you have to read each answer choice, you know, and really think about it. And if you think about it, that's the only way it could be, right? Because if it's it'd be on the left side, cervical compression reveals hidden cervical discs, which also coincide with anteriorities. When the cervical disc fails to any degree, the vertebrae is going to translate into anterior. Maybe on one side, other, or both, but that's how it goes. So when you're doing this, you're testing for hidden cervical disc, you're testing for hidden cervical subluxations, things that aren't showing without doing the compression. But brachioradialis, C6, innervation, left side, compression, that you have to kind of think that through. And that actually was a pretty good question, but a lot of people missed it. So I wanted to make sure you really got that. And typically when we do anteriorities, we're adjusting for C4 or C5 anteriority, there's going to be a little bit of S to I vectoring, because you're following the facet lines on the pillars. So anyway, okay, so number 40 was also kind of weird. Okay, she got it right. Number 40 was really tricky, and it was another one like the one we just read. An isolated carpal tunnel syndrome will demonstrate which pattern of muscle weakness. The correct choice is opponens pollicis weak, opponens digiti minimi strong. That's the correct answer. So we're talking median nerve innervates, you know, basically here. This is innervated by the ulnar nerve. So this muscle is going to be weak if you have pisiform hammy syndrome. Just pisiform, you know, crowds the ulnar nerve. So that's the correct answer. And there were quite a few people missed that. I want to make sure that one. I think that's a really legit question, but I want to make sure everybody really gets it. Moving right along here. Is this helpful?
Yes.
Do you have any questions so far as you're looking through your own test? Number 49 was, I think I threw this one out too. The test is, the question is legit, but I really emphasize ocular lock and its relationship to switching and all that. And the correct answer on 49, number 49, is C, K27 umbilicus. Now, a lot of folks put upper cervical adjustment, which I agree with. That's one of the quickest ways to get people in switch. And that's kind of how I taught it. But because of that, the answer they want is K27. So I threw that one out. So if you got it right, that's great. But if you got it wrong, but I want you to understand that it's kind of the way they think versus what, because I feel like ocular lock is such a valuable technique for clearing switching and all kinds of things that I think it's kind of, anyway, I'll say no more. What else we got? 57. I think almost everybody does this one. The doctor places blocks transversely at the level of S3, this is the key word here, S3, and tractions the left leg. Previously intact tensor fascia lata weakens. What is the condition and level involved? Now, this is for imbrication, right? With the person on the blocks and you traction leg, you look for weakening of the strong indicator muscle. And that indicates that you're challenging a facet which is jammed. And when it pops back together, i.e. rebound challenge, you get a positive muscle response. Now, the thing is, you put the blocks at S3. So you're not even up into the facets. You're below the lowest facets. So if you do that challenge and test, you're not testing facets, you're testing something in the hip, pelvis, knee. It's testing something, but it's not that. So a lot of people put L5S1 imbrication, which is good thinking because they understand what the technique does. But if you look at the S3 thing, then that tells you that it's not going to test any of those. It can only tell you you've got a hip or knee problem, and that's the correct answer, number D. Does that make sense? So if you're testing using any kind of challenge like that, make sure you're affecting the thing that you're wanting to challenge. 59, 57, 65. 65. Okay, so 65 is another hidden cervical disc one. And the correct answer is B. And it's biceps and deltoids test strong but weaken upon cervical compression. The brachioradialis remains strong. Which do you suspect? So they give you several different levels there, spinal levels. So you're thinking deltoid biceps, that's higher up on the brachial plexus, right? So the highest one there is C4-5, and that's the correct answer. But then, hidden cervical disc is C5-6, maybe not. Some would say it's C7, probably not. Then now you're getting into like tricep and whatnot. And then the C7, a lot of people put C7 first rib. Several people did, which is incorrect, but it is what we see with what kind of fixation. It was a one-sided fixation. What's that? Limbic fixation. Limbic fixation, which affects all of the muscles on one side, all the ankle muscles on one side. Almost all of our fixations affect the bilateral muscle weakness, but that one is kind of unique. Here's another one. 67. Which common reactive muscle pair tends to restrict thoracic excursion on respiration? This was commonly missed, and a couple of the answers, like hamstrings, rhomboids, are kind of like, far-fetched. But abdominals and diaphragm, a lot of people chose that. The answer they wanted was psoas and diaphragm. So we talked about the diaphragm and its interrelationship with the upper part of the psoas, how the psoas interdigitates with the diaphragmatic crura in the back. And the tension of the psoas is what helps bring the ribs into excursion like that. So that's the correct answer. And I think I threw that one out, but I want to make sure you understand it.
Dr. Donnie, for 66, when your hip is adjusting in the direction with the weakness for a vertebral challenge,
Oh, yeah.
wouldn't you go opposite if you're?
Well, okay, 66, right?
Yes.
Yeah, when using an AK vertebral challenge, adjust in the direction which produced weakness. It's true, but it's confusing. What they're implying rebound challenge. They should have added more verbiage to it. You're doing a rebound challenge, and so if you do the rebound challenge and create weakness, that's the correction you're going to go. But you have to. They're implying rebound challenge. Yeah. So yeah. Did you get that one right?
No, it does think it was static, so
Yeah. I think, and that was, yeah. I don't think I threw that one out, but that was one that several people missed. That I, okay. Where are we at? 71. No, we already did that, didn't we? No. Okay, 70 and 71. Whew. Okay, the need for injury recall technique for an inhibited weak muscle is indicated by temporarily refacilitation after the correct answer is rubbing a suspected injury area. And some people put rubbing the muscle, some people put stretching the muscle, but the correct answer is rubbing the suspected area. Now, it could be a muscle, it could be a fascial area, it could be a number of things, it could be, just it could be an issue in the skin that may injury. So you rub an area. Say somebody, a real common was somebody's had an appendectomy from finally come in and big old scar and they've got pelvic issues. Well, I'm definitely going to do a quick check and see if that scar is just eating into an IRT. It could be 5 or 10 or 20 years ago, but an IRT pattern going on there that you need to fix. 70. Okay, 71 craniosacral. Challenge for the internal frontal cranial fall is, this one was commonly missed. I'm not sure I went over this one well enough, and I honestly think I took this one out too. I gave this, I negated this one. But the correct answer is in on the malar surface, in on the malar surface of the zygomatic bone. And we did. Now the external frontal, you pull on the incisor. So that's kind of a goofy one, kind of easy to remember. I think that's 72. Hey, some people missed 72. That was the cat 3. The correct answer is prone, walk straight across, moving one down until pain reduces. Remember, you put them in straight across, and then you ratchet down. That depends on where your TL was. If your TL was, I'm sorry, your challenge, because you don't have TL with cat 3. It depends on how you're challenging. You challenge it one side, challenge the other, and this side challenges. Then you put your block straight in, and then the lesion side, you start ratcheting your blocks down until the pain. Usually you use the glute trigger point or right over L5. 81, which cranial correction is most associated with pineal problems? I think if anybody listened to me yesterday, and some people did because they got it right, we just touched on that, and it's the mandibular spread. That's for pineal. And I threw that out. It was in the slides yesterday, but I may have given that one. The other one, I was surprised. Which acupuncture points are next to the spine? Back shoe points. The associated points, and I had answers kind of all over the map. Well, not all. Some people put alarm points. Okay, there was a few maybe more missed than I was comfortable with knowing the relationship of the meridian or with the muscle, like, or what element like a certain muscle was in. There was a few that, which of the following meridians are Earth? You know, the choice was large intestine, spleen. This is number 82. And one person put liver. But spleen, of course, is the Earth. Spleen, stomach is the Earth element. And that's going to be, Earth element's going to be pec major clavicular, lat, middle and lower trap. So neurovascular reflexes discovered by Bennett. A couple people got that wrong. Neurovascular are the ones that we hold and feel for pulsation. The stress reflexes they respond to a linear, a directional tug and a respiratory negation. So you strong indicator muscle weakens, breath in or out negates, and that's how you treat it. A lot of people got this right. I was pleased with this. A lot of people got 84, the iliolumbar ligament, because I thought we kind of didn't dwell on that enough. Kind of ran through it pretty quick. So to correct a strain, counter-strain trigger point, press on the muscle spindle in the direction to weaken the muscle. That's incorrect. If you correct a strain, counter-strain muscle, you spread the spindles as if you're going to strengthen. So everything about that statement is correct except the direction that you spread the spindles. And there was another question on this test. Make sure we have time for the other ones. Where I just lost my train of thought. I was between. Yeah. So the correct answer for stress center, cranial stress centers, is the pressure in the direction of weak challenge on the phase of respiration of strength. That one was kind of missed a few times. We didn't talk about those enough either. So now, inspiration assisted sacral wall. Several questions about that on test M, number 90. The correct answer is A to P on one ASIS and P to A on the opposite sacral apex. That's for inspiration. Expiration is the opposite. You push P to A on the sacral base, and on the opposite sacral apex, you lift up. You kind of get under it best you can to lift up. So you're mimicking the motion it goes through in expiration. Sure, I think so. D. Okay, so number 95. The right wrist extensors test strong but weaken with cervical compression. Which adjustment is most likely? The correct answer is posterior and inferior on C6 on the right. That's the correct answer. Once again, it's like cervical compression, think hidden cervical disc, and think anteriorities. So when you adjust an anteriority, you're going to adjust it back to where it's supposed to be. And I think those are the key ones that I had. That some of these I threw out, some of them I didn't throw out, but they're enough folks missed them. I really wanted to make sure. Any questions on any of the other ones on the M version, and then we can, Listen, how we doing? You have some comments? Data. Any questions on the M test or any other thing that we covered? I think.
Is infraspinatus a prime mover of external rotation? Or, because I know it does like abduction, because this is the test, right? So.
Several people miss that one too.
Yeah, I thought Terry's minor
It's-
was like the prime mover.
Thank you for your
In this position, in this
There's so many
position,
things I got done and I was like.
Terry's minor is kind of, Terry's minor might actually end up being almost infinite.
Also,
I
right,
feel like this was hard.
It was, yeah, we discussed. Yeah.
So,
because this morning he was like,
So-
they were the same. Yeah.
you're on.
I'm
Listen,
on, I'm ready.
listen.
Hey. Okay, y'all, so if you had the L test, I apologize. It seemed like it was a lot harder than the M test, kind of comparing, like just average scores and things like that. So it's not you, don't stress. In fact, I'm an analytics person, so I don't know if you guys can see on my notes, but I have like data for yeah, so in case you're interested, but there were 36 questions that half or more of you got incorrect. So that just tells me that the questions were freaking hard. So like, don't go easy on yourselves. But there were a few that I just want to chat about. The wording was a little weird on some of them. So I'm just going to show you some of them that were a little funky. And then just some things that we kind of covered a little bit more in depth. And then if you guys have questions, please. Number 5 is about GTOs. And I think this was a wording issue. The correct answer was D. You push apart on the ends of the muscle to decrease the tone of the muscle. It's the opposite of regular muscle spindling, right? So I think that got 87% of you guys. Here I go with the percentages, sorry. But opposite of the spindle cell. So you'd push apart on the ends of the muscle rather than right to weaken. Just wanted to go over that because that's, you guys are going to be using that every day. I don't know how many schizophrenics you guys are going to be treating. I don't treat very many schizophrenics, so we're just going to let that one go. Number 14.
Listen, could you, there was a question earlier about the schizo one. Could you read that? Would you mind?
Yes, let me read it out
I'm
loud.
curious.
Let me find it.
Karen, you asked about that.
Yeah, I just felt personally victimized by it. So I read it and I was like, oh no.
Are you ready, Dr. Dombey? Do you have a copy of the test? Is it easy to look
What
at?
number is it?
57 on page 9.
Okay. E should be the right answer.
Ah,
And I don't have the key in front of me, but that's what I would think. That should be the right answer.
It's not. Hang on a minute. It was apparently D.
Yeah, that'd be worth questioning.
Yeah.
Because
The majority of you did choose E, so I would have also chose E in your situation. So
yeah,
I think not my favorite question that you guys were asked.
they found that a lot of schizophrenics would actually strengthen the homolateral crawl. That didn't mean it was good for them necessarily, but it meant that it was that level of switching. So, but yeah, that is confusing. Did you just throw that one out?
Yeah, that one's long
Good,
gone.
good.
Okay, where was I? 14. 14. When challenging an extremity joint, this was also a strange kind of wording, but you're challenging where you can't do rebound challenge on extremities. We all know that, right? But you want to know which position the joint does not want to be in. So if I'm testing a shoulder and I jam that shoulder and it causes a weakness, that shoulder wants to be pulled out of the socket, right? And vice versa. So that weakness just tells you what direction the joint doesn't like so that you can correct in the opposite direction. If you had a strong muscle and you were looking for strength, you don't know if that's the body being neutral to that challenge. You don't know if there's, there could be nothing wrong with that shoulder joint. So you would find the weakness, correct in the opposite direction of that weakness. So that was number 14.
See,
Yes,
that's correct.
yes, C was the correct answer. I don't know if I said that out loud. Number 30 got quite a few of you guys. Which muscle is most likely to test weaken and postural hypotension? I think we chatted about this yesterday before you guys took your test, but the correct answer is C, gracilis. It is because it's an adrenal-related muscle, right? So if your adrenals are crap, you get postural hypotension. That's where that's
So you
what
legitimate in that more blood pressure, not like posture.
No, like standing up from sitting down.
I
Or
was
whatever.
gonna
Yes.
ask, and I was like, you mean this or this, but now.
Yeah. Yeah. If you slouch, your blood pressure goes down about 10 points. Yeah.
Well, I was, yeah.
No, you're good.
I read that so wrong.
No, and I was reading over something. I was like, are we speaking English? I don't know what's going on. I think the next one that I want to talk about is a little further down the road. Oh God, far down. Okay, we're gonna jump to number 67. That's on page 10. This was a question on a coccyx challenge, and they gave you a lot of sexy answers of things that you should do to this coccyx. You just have to adjust it. The coccyx was out, you want to put it back. You don't have to worry about any secret tuberous, like none of the things. Don't worry about it. The coccyx is out, we just got to put it back. So the correct answer for that one was C. I love option E for this one. That's crazy.
Sorry, is C?
Yes.
Activator
67.
adjustment to coccyx? That's the correct answer? Interesting.
I put D on you guys. Wait a minute. Don't.
B would be,
Don't
B would be the correct.
Wait. I read the wrong question. I'm so sorry, you guys.
You read it wrong too.
Yeah. Yeah, me too.
Someone rubs it, excuse me. Actually, that would make so much sense. No, it didn't. I was like, get out.
Okay, forget what I said. I don't know what happened there. Regardless, I had a few people put E for that one. If you want to do all that acting, that's fine with me. But pretty simple.
Can I ask a question on 59?
On which one?
59.
Yeah.
Why do we pinch rather than red?
Oh, okay.
Yeah, go ahead.
Because pinching comes out of Wally's thinking, pinching activates nociception, but rubbing activates other receptors. So that's what way he would rub, because it brought up it would trigger the patterns of the IRT better than pinching. Pinching would create nociception, and that would override those other sensations. It's probably the best way I can describe it.
Wait, so you saying we should rub or we should
You
pinch?
should rub.
Okay, this one says that we should pinch. Yeah.
On the M test, it's rubbing is the correct. What number is that?
59. I'm not saying the test is wrong. I'm just saying I don't know
No,
exactly
right.
the concept.
Treat injury reflex for injuries above the clavicle. It's best to pinch, rub the area of injury, and passively flex the arm. See, the answer, there should be B. They're saying A. All right.
That one got thrown out, so don't.
Yeah,
like,
that-
stress.
I just want to make sure when I practice. I'm
Sure,
doing
yeah,
testing,
pinch,
because
rub, yeah.
I guess
Rubbing.
makes a difference.
Pinching is when you want it, like he would use pinching over a Chapman area or over an organ reflex area. He would want to, when he wanted to initiate nociception, to see how the body was handling that. So he would distinguish between pinching and rubbing, but rubbing for IRT has always been standard. So, yeah, I think that you threw that one out.
Yes, that one.
Is what I'm doing.
Okay, a couple more.
Did you make notes on? Do you have a copy of this with notes on it? Because next time I give these exams,
You can have this chicken scratch. We can talk about what.
because I don't want to have to do this again.
Sure, right. Some postural stuff got you guys, so I just want to talk about that really quick. Number 79. having a hyperlordosis of the lumbar spine is consistent with bilateral weakness of. This got every single one of you guys. The correct answer for this was the glute max. So if those two are off, right, then your quads, your anteriors can pull down on that entire kind of pelvis, and that causes the hyperlordosis of the lower back, right?
Wait, what did you say was the hypolordosis?
Hyper.
Oh, hyper.
Yeah, we're gonna go hypo next, but yeah, if those two glute maxes are off, they're not pulling posteriorly on that pelvis, so you get that anterior tilt and you get that hyperlordosis. Now, if they asked you the opposite question, which I'm sure confused the hell out of most people, 85 was the complete opposite of that question. If you have hypolordosis of the lumbar spine, that would indicate a bilateral weakness of the psoas. So that psoas is now pulling that pelvis forward, creating less of a curve in that lumbar spine. Does that make sense? Okay. I know it's hard to kind of think about, but 83 got so many of you guys just because of the wording. Augmented inspiration means forced inspiration. That's all it means. So I don't know why we had to get fancy with the wording, but that one got you guys. So. Okay, I think I have one more for you. Hyperlordosis would be bilateral glute max.
I just read Cert June.
How'd they do
I'm
it?
kind of confused about that because I know that Max does mention, so if it was trying to do that, it would.
I think what was confusing is yesterday, or on the review, you went like this into the hip spelling, and it was psoas, but I think it was just worded differently on here. Because I had in my notes from the review, forward hips equals psoas, but I think it was just explained.
Forward hips this way.
I'm not saying.
Yeah, you see what he did?
No, I'm not saying.
Forward, yes, but it depends which forward you're going. If that's a bilateral psoas tightness, you see what happens to his low back doing it.
What was the one that you went like this for? Like with your hips spilling forward and like.
Spilling forward this way.
Yeah, like an anterior pelvic tilt.
I'm trying to remember what we were talking about. What was it in regards to?
I don't know. On the review, I put.
Right now, we're talking about a bilateral glute max weakness causing hyperlordosis in the lumbar spine.
Hypo.
Hyper.
Hyper. So glute max weakness makes sense for hyper.
Yes.
Because the glute max should be doing this, and it's allowing this.
Right.
But I
We
think
got weak abs, weak glute max.
we like talked about the concept, but in a different way, and then I just got
Oh, I see.
mixed up.
I see. I don't know what happened.
We talked about the
I
same
wasn't,
concept.
so.
Yeah,
I
it's not a you thing. It's a.
There was another one on the other test that was, there's one on the other test that was rectus femoris was the correct answer. I think we threw that one out too. It's kind of true, but it's not, it's like misleading. Rectus femoris, weak can allow pelvis to come back this way, but usually not on its own.
It makes sense.
Rectus femoris could do this, but usually the psoas is helping. Anyway.
That's my one thing.
Okay. Those were the big things that I thought we should all probably know. Do you guys have any questions that we should chat about? Yeah.
I guess I'm still kind of, like I said, I thought that the trying to do this one.
So, let's say you're right. The glute max does do extension of the hip joint, right? But if your glute max is weak, what's going to happen is your antagonists are going to be pulling. They're going to be a little bit stronger, right? If these aren't firing. So if this isn't doing its job, then these quads are going to pull on my hips and pull them forward. That makes sense? Because these get shorter, these loosen, and so it creates that hyperlordosis in my back. Versus if my psoases are super tight, they're going to pull these hips down and forward, creating that hypolordosis. Makes my lower back flatter. Does that make a little more sense? Cool. Yes.
It was like the restricted right side
Then my head was like, but like lateral flexion.
No.
Let me see if I can find it.
Which one are you on? It's 46.
46?
Yeah. I2 is like
I mean, I'm on the opposite.
restricted to the right. Yeah.
Lateral bending is restricted to the right, which muscle is that one?
So that would be, you would be more like this. Yeah. You would think of you're more like this. And this is restricted.
If it's weak, because it can't force.
But then I did the
Hamstring weakness. A lot of times the hamstring
Right.
weakness, you see more of a sort of.
Yeah,
mechanical
it's not
movement to it.
If it was weak, would it be
This thing here, using tight so it has weak.
Well, it's weak. The other side.
So if it's weak,
patient
would
lateral
it be
bending
like,
is restricted to the right.
it wouldn't
I
be
always
like
knew it
loose?
was weak. I always thought it was like weak. No, because the side would be.
So if that right weak sacrum, if that right sacrospinalis is weak, right, then the left side, like, it's the whole antagonist. The left side is now pulling on that back a little bit more. So if this isn't functioning, I'm not gonna be able to engage that muscle to bring it over, right? So, yeah.
It made sense on this one for me. The other ones, I just went into that.
Oh, I was like, opposite.
No, they were tricky questions, and like, it's hard to think about the agonist and the antagonist, but does that answer your question?
Yeah, okay, about it crawling. I was like, I didn't even.
By the time I got to 60, I was like,
All right, y'all, any other questions? I know that one was a rough go of it, but you guys did great. We have a room full of PAKs, everyone. Very nice. Okay.
How many is that? How many?
Yes. Yeah, oh yeah, Adam girl.
2, 3, 4, 5, 6, 7, 8, 9, 10. And then,
What did you choose? Did you choose ND or NMG?
I do NMD.
I know, I'm like, I guess I just did ND, but I was like, I'm not ND.
I know, it's
the most
hard,
I've ever
but
Yeah.
I know, it's so exciting. I just ordered a new, like, hair.
oh, I know, I saw the ones that you have. So cute.
And we had.
We did.
I'm hungry.
Yes, yeah.
I felt so relieved when I went home yesterday. I was like,
I felt like,
I didn't read a comprehensive.
Oh, no,
and I was like, so sad.
I felt the same way when I took this test, and I was like, when we got on the phone, I was like, something's really not right here.
Classes, I've seen classes, unfortunately not mine.
I literally halfway through, I was like, I should have taken more adrenal, and I was like, let me just like.
Wow.
I
knew that during classes. I don't know why. Sorry.
I just need to pee and give me some food in the middle. I was like, ah.
Nobody signed up.
Oh my gosh, you guys.
Next year.
We made it.
We're, we got the
I'm
first
so
3
proud of
sessions.
every single one of you.
I let people sign up.
Square makes more sense than
Month by month.
well, that's why I said I don't feel like this is a good indication of like what we know because I.
And that's the thing, right? This is an overview of AK, right? There's so much shit under the umbrella of AK. Like, you're each gonna have your little niche and how you practice and how you approach people. Whatever, you're gonna use this thing a million times. You're never gonna use this thing. So, like, it's not fair to be like, oh, let me ask you 20 questions about the 5 elements here. You don't want to do any after this break, you know?
Yeah.
So, like, you just have to get through this test and do whatever the heck you want.
Exactly. That's what I've been telling myself.
Yeah. And in case I haven't known, Buster, so, like, open your books, this is what we're doing today. Huh? No, I said Buster.
I heard what you meant though.
Yeah, like, you just open your little book and
Yeah.
how did everyone fare when they took the acupuncture shot? So where did you do one?
Well,
Between, it was zombie and.
how did everyone do? I don't even know how many people took that test. That was a tragic round of this course. I brought him back so fast, you guys. I was like, we're not doing that anymore.
Yeah. I didn't even know it was like some weird dude.
Yeah, I almost took that one and then I was like, let me get through boards one first. She's not there. I'm like.
Oh.
I was scared for my life the entire time.
You're like, no way.
And then he tried to front me off the yoga.
Oh gosh. Cherry on top.
Weird. Are you kidding me? Disgusting.
Are we giving these back to you?
No, you can keep it for,
Oh,
frame
really?
it for your family or something.
Your family.
What? Test? Oh, no, I need the test.
Okay, that's what I thought. I was like, that would be strange if you let us keep these.
Otherwise, you can pop.
Yeah, that's what I was like.
Right? I mean, not that you would.
Yeah, I definitely.
Because I didn't get it done yesterday, but I brought.
Sorry, I didn't tell you yesterday, I'll have to have it back. Hopefully hopefully I can.
Oh, no.
So I was gonna say they take some stuff out.
This is for big.
Yes, to average.
Yeah, my math probably is not right.
You want this?
How many hours do you do? It's 8 per day.
Yeah, 7 sessions. Well, that was
I took it out of 13.
2 days.
It should be,
Because I was like, it should be 100, but I think mine was.
I go NMD.
it's a little more than 100 hours.
Yeah.
I think,
Because I might have not.
All right.
yeah, and it's these will just go with the.
Oh, yeah, if they want to see my phone, they can yell at me.
The ICA camera wants like.
But, oh, yeah.
They have a
It was like, I'm like, what cares? I was also like, they're like, yeah, that's so
In fact, I'm collecting, she's collecting it for me, so I've already got a stash.
There's 2 color exams.
We can.
Okay, you took your guys' yes. The first college exam. I just yeah. Yeah, exactly. I'll just.
I'll take it home for a snack and I might look at it.
Yeah, just know that your F version is.
Try the peeler.
Yeah.
I feel like I do. I just like.
Honestly, I liked a lot of the questions.
Yeah.
Some of the questions I thought were good. But. That is just some data.
Something, all right.
So before we leave the test discussion, is there any other questions or comments or concerns?
Oh, yeah, I'm watching something. Thank you for asking. I appreciate that.
Guys?
It's evolved,
So, we still have lunch left over from yesterday?
I think so.
That's an L question? Yeah.
So, it's almost 11. I figure we'll probably do lunch about 11:30 or 12, right? And this is the end of my slides for session 7. what would you guys like to do the next, besides have lunch?
Adjusting.
Adjusting.
Practice.
Adjust, okay. Um, what would you like to see or practice, or what kind of adjusting? You have, does anyone have a specific interest in looking at a specific kind of?
You want to jot this down maybe on the whiteboard?
I don't know how to do cervicals in general, but anterior cervical, I don't know. If you want to talk about refining that.
Anterior cervicals.
Yeah.
How do you adjust one side?
Or
That's kind of
rib 1, 2.
Yeah, rib one would be.
yeah, rib one.
I can teach you how I do it. There's several different ways to do a lot of those things. The way I adjust anteriors and first ribs, I can show you how I do it. And I do it the way I do it because that's what works for me. I don't do it any other way because I tried other ways and they don't work for me. So that's why. So hopefully they'll work for you. I'm not sure which side is wider, or this side has a lot of weird stuff on it.
I can clean it.
What were you saying? Should we just
Well, I think
write-
like we all have like different things we wanted to see, so I don't know if we want to create like a
That's
list.
a
Do
good
you want me
idea.
to clean the board?
Or somebody could just write down, Dr. Whitney, she likes to use the whiteboard. She was here.
Here's that.
What's that? Well, it doesn't look very, yeah, that doesn't look like it's an eraser.
Got you.
Oh, she's got it.
Oh, you got it.
I was looking for it.
So,
There's another one.
so, since she's done, I want to talk about, the anteriors. I want to talk about the cervical spine in general first. Now, this guy's missing his atlas, so just imagine an atlas there and a skull. But I want to pass this around just so you guys get one of the test questions that got missed a bit was about vector of correction. It was, like C5, C6, anterior, posterior, and anterior with an inferior vector. If you look at, I'll just pass this around. If you look at the facets in that neck, because if you're thinking about your vector of correction, you're kind of working with the facets. That's really what you're adjusting. That's really what you're impacting on a vocal tissue level. And oh, sure, yeah. I do it if they have facet syndrome. Now, if they're really in an acute phase, then sometimes you got to let it lie for a while. Oh, sure. A lot of times, a facet syndrome is this facet's chronically kind of jammed, and it needs to be kind of opened up and gapped, and that a lot of times will help resolve the facets. But you got to be careful with them too, because they can be really gnarly.
Can we also go over safety?
Okay, let's do sacral wobble and lay it to rest once and for all, and then we'll go to. Yeah, that's. Well, she's getting us.
I don't know what I'm doing.
Okay. Well, once you get some space, write down anterior cervicals. Write down. Sure. Yeah. Yeah, just so we have. So I'll lose my train of thought. Someone come up here that might have sacral pelvic issues. We're looking for sacral wobble. Somebody's going to have it.
My sacral moves in
No, we don't, let me have you stand. So we don't, you got something going on. Your sacrum is moved to the left. Can you lay face down? sacral wobble, and then let's put down upper cervicals. And then you can put lumbars after that. We'll see what we can get to. And then after that, put extremities. Fixation, sure, fix it good. Yeah. Okay, so what am I going to do? Sacral wobble. I'm looking for sacral wobble, but I would be looking for all kinds of things. And if I saw posturally that the sacrum was a little this way, hold it there. So she's got a weak hamstring. So I could go straight to sacral wobble. Put your hands in prayer position, just for the interest of demonstration. Look at that. That would get it right there. Now, I would also have her do a cat 1 TL to see if that turned on. That doesn't. Cat 2 TL. Yes. Cat 2 TL. No. So she's got a cat 2 on the left. I'm not going to. I could try to fix the sacral wobble, and then see if the cat 2 clears. But I probably, if I was in the office, I would clear the cat 2 first. Lay back.
Why would you clear cat 2 first?
Because it's more important. It's a bigger deal.
Because I guess the way that I think about it is that like the sacrum is like the center of it. It's better to adjust that first before.
Well, cat 2 involves more stuff. Cat, yeah, I mean, cat 2 is really, there's a disruption of the whole kinetic chain. And a lot of times with cat 2, you'll see a lot of times you'll see these anteriorities on the same side. A lot of times you'll see a lot of times brachial plexus problems. There's also a cat 2 on that side. So with the sacral wobble, I think of sacral wobble as more of a finishing touch on the pelvis, biomechanically speaking. But I mean, the sacrum just does what it's told. I mean, it's sitting there with all these forces coming at it, and it's, it doesn't have a lot of movement. Okay, so if I challenge her, quick and dirty, challenge her, she's got a left PI. Take my handy dandy blocks. These are so light. How do they make those so light?
They're old. That's why.
I mean, they used to be heavy. We could burn them down. Okay, so now what I could do, go through all the steps and check LLL, UMS, but I'm going to go in and just challenge it that way. I could do that and there, yeah, and then look for leg length. I always check leg length, but now while she's on the blocks, I'm just kind of making sure her body's kind of relaxing and kind of melding into the blocks. Take a deep breath. Breathe down. See, when she's cooked, she goes back like so. And the faucet comes back. Probably still a few of those. So I'm taking these blocks out, and they should take them out at the same time. Now, always come back. Same challenge you used to go in, you make sure it's cleared, make sure you didn't miss anything here. So, on here, ICV, do an enhanced TL, augmented TL, right? Increased, amplified, accentuated, right, Melissa? Augmented?
Yes, augmented inspiration.
Means increased, like it forced inspiration, like for Spinoza. It's a fancy way of saying forced or increased, amplified. Let's all use augmented. In the next hour, everyone needs to use augmented in some particular way. How about that? Okay, so lay face down. Yeah, we're gonna, yeah. What if the cat 2 fixes the sacral wall? Whatever. Now she had weak hamstrings in the clear, remember? That's strong in the clear. Strong in the clear. Now the sacral wobble TL, please. Back to strong indicator. She still has it. So Now, what do I do next? Breathe in. Deep breath in. Breathe in and hold it. And breathe out. And breathe out. So she strengthens on an in-breath. So it's an inspiration assist sacral wall. Which side is it? I don't know. I'm going to challenge both sides. For inspiration assist, the right nominate and the left sacral apex, I push here and pull here. And now, oh, wait a minute, I skipped a step. I need a strong indicator muscle. These muscles were actually, well, they seem to turn on after the cat too, but I think, push. I need a different indicator muscle. Yeah, there we go. So, nominate, apex, and that's it. Okay, got lucky. I could go to this side, left and nominate, nothing. So it's this side. So, go ahead and breathe in, breathe out. You know, you'd think maybe the blocking of the cat 2 might take this out if it more time. What's that? It might. Let's see. Now, see if this is back on. No, not yet. Push. Yeah, good. Now it's heel. Hold there. Yeah, so that doesn't show now. Try both sides. Oh, no. Heel. I mean the cat. Wow. There you go. Now she's good. Okay, now cat. Just to be, oh, look at that. She does have a cat. Okay, she didn't show cat 1 first, right? Okay. So what do I do next? This is the positive TL. Now I do a double. See which side is lesion. It's going to be the left. So then we go like so. We go. That's for, and there it is. Okay, so the blocks go this way, right? Challenge this way, blocks this way. Yes. So you've got the trifecta. That's right, right? We challenged this way.
You challenge this one? No.
Challenge. Okay. Challenge. So this way, I block this way.
That happens the way I'm looking at.
Yeah. Okay. All right. Now, if I'm not sure if I got the blocks, if the blocks aren't right, then things start weakening. That one's a little bit. There. Let her simmer. And breathe in. Breathe out. She's really tight right here, so just kind of let that. Now, so that was the inspiration assisted sacral wobble, apex nominate. If she had an expiration assisted sacral wobble, which was one of the questions on the M test, I think, then you go sacral base, apex. So you're kind of doing this with the sacral. You get under the apex best you can. And then you go both sides, and that's for expiration assist. So you treat on expiration. Well, you kind of get off the apex. You kind of get under it this way and just kind of give it a little push this way while bases. I mean, you don't go like, you don't try to get too basic. Still cooking. When she's done cooking, those muscles will melt away. Let's check the first rib thing, because that's part of it too, right? Her T1, it's a little, actually your T1's a little bit this way. But we don't want to like complicate, we want this to finish first. I don't want to start challenging vertebrae while she's still on the blocks. Too much confusion to her nervous system and to me. Breathe it deep. Let it go. I'm just going to see if that kind of, it gives me something to do on the way to the blocks. So, okay, so she's good. Now, once again, cat 1, TL for cat 1. Wait, let's get our baseline, sorry. Push, push. Nice. Cat 1. Okay, good. Okay, please rise. So, cat 2, we wanted to show sacral wobble, but she had cat 2. Cat 1 didn't show. Did the cat 2, cleared that, seemed to be. And then we went back to sacral wobble, still showed. Cleared the sacral wobble. Went back, now cat 1 shows. Sacral wobble clears, cat 1 shows. That's not uncommon. Now we might keep going, we could probably spend all day keep digging a little deeper. So, sacral wobble, everybody good? Everybody's good? As the phase of respiration that negates the initial finding, TL finding, sacral wobble, determines your challenge. So with anterior cervicals, that spine back, please. Oh, this guy's missing an anomaly. Oof. I've probably told this story before, but when I was early in practice, I had this young man come in who was missing his entire, I think it was his right arm, and his entire right leg. He was going from about here down. Comes in on this side with a crutch. Otherwise, super healthy young man. He had been hit by a train on a motorcycle, and he walks in and he wanted to know if I could adjust him, and I did. I adjusted everything, but I'd never adjusted someone that was an amputee. Now, since then, I have a lady I see fairly regularly who's a little older than me, who is a thalidomide baby. She's got all kinds of stuff missing, and she's missing her leg from here down. Her arm is just like this on the right. She's all kinds of weird stuff in her skull. I mean, weird like shapes and stuff. She's a real interesting lady. She carried and delivered 4 children. They're all grown now. Yeah, she's amazing. Pretty opinionated too. She's a force to reckon with. So anteriorities often, and a lot of the chiropractic and osteopathic and naturopathic adjustments that get done often are posteriorities. And the very first adjusting I ever learned in chiropractic college was adjusting P to A. We didn't really learn anteriorities. I actually learned how to adjust anteriors from a kind of a workshop I went to that was sort of given by a guy who had just actually only been in practice a few years. And I learned a lot about anteriorities and lateral adjusting from that guy way back. But in school, everything was P to A. And when you're adjusting P to A in the lower cervicals, what are you affecting? You're affecting the facets primarily. But if you have an anteriority already, say you've got one of these category 2 situations where you got kind of a chronic cat 2, chronic short leg, and you end up with this kind of thing. And these are the people a lot of times will have a weak tricep, they'll have a weak lat, and if I turn them into this position and reduce the anteriority, everything will turn on. That's kind of a classic pattern I see a lot. So, but if I adjust those anteriorities P to A, it's not gonna help. You may get movement, it may relieve some of the discomfort for a period of time, but you're really not making a real correction and not helping the nervous system, reboot how those vertebrae are managed. So I think anteriorities are super important too, and you don't have to be hard with them. You're not going to want to be hard with them. You want to do them very gently and be aware of how many delicate structures you're pressing through. The way anybody have a besides Jeff? Yes.
I have an anterior C1 on the left.
C1. Okay, well, come on up, we'll see. Enter C1. Based on,
You can feel it.
oh, okay.
If anybody wants to feel it before he fixes it.
Well, I don't know if I'm looking for lower cervical, but we'll see what we got. So let's start with you, and we'll just find a strong indicator. Can I take your glasses? Let's find a strong. I'm going to feel a little stumbling. Okay, so it's strong in the clear. That one's strong in the clear. Go ahead and we'll do ocular lock. Close your right eye. Close your left eye. So eyes open, look straight to the left. Eyes open, look straight to the right. So eyes up to the right. Eyes down to the right. Okay, so we'll leave that there for now. I'm going to go down the neck to the lower cervicals. Is that tender? That tender. She's got some lip nodes going on. She's a little bit, her lower neck is a little bit over, kind of a bit this way. So this is what points me to anteriorities. I go in and that tricep, she's strong. I shouldn't be able to do that. And I can't there. That's one of the first things I do. I also will check the serratus, because that tells me how much, see that's now come down. And I like, drop it down. I like to, that's kind of weak. We could check the lat too, stand up for a second. And pull in. Yeah. So go ahead and have a seat again. We could check the scalenes, hold there. Scalenes kind of weak and pretty good. Now, did you have a car wreck or something? Mm-hmm. I thought, okay. So you've had real trauma in that neck.
Yeah.
Yeah. Okay, so a lot of these things kind of make sense. Upper trap, shoulder up. Turn a little bit more there. Upper trap, not so happy on the right. Upper trap. That's pretty good. So the more information I can get, the better I like it, because then I can go back and see how much of the stuff clears. Now, disregarding what we already found in her upper neck, and one could argue that we should clear that first, but that's probably been cleared.
Yeah, it keeps coming back.
Yeah, so we'll just let that sit for a bit. And I know this needs some attention here. This is just kind of bunched over here. So first thing I'm gonna do is I'm gonna slacken her neck until it feels like it softens under my thumbs. I can show this on you guys. We can workshop this. Softens right there. And we'll kind of start with that. And right there, it's like, hold your head in that position. And we come down here, push down. And that starts to turn on. That's not 100%, but it starts to turn on. Now, let's just tip you a little more. Push. Yeah, that's really strong. Right? Now, what else do we have? Is serratus. Come up this way. Push, push. Serratus is fine now. Push, push. Yeah. So that position is where her nervous system is like, oh yeah, that's better. That's where it's happening. So her C5 on the right is kind of jammed anterior. So when I put it in that position, it's happier. It's slacking because there's no tension around it. But it's obviously she can't walk around that way. Now the other way I could get at that, this was already this was already weak in the clear, but we could find another one here. Go ahead and push down on your head. Cervical compression. See, that's cervical, hidden cervical disc. Take that away. Come out this way, make a fist, roll it back. Strong, right? Push down on your head. So that's what they, like some of those test questions were about. Now, we all know this creates this, which creates anteriorities. And then you think about, well, the nerve root level. So C5-ish up here, right? C5-ish, C6 here. And then you get down into here, you're getting down into C6, 7. So that's kind of how you think. Now, you have a C5 nerve, you have a C6 nerve, C7 nerve, and a C8 nerve. Comes out between C7 and. So I need to adjust her here. I need to adjust her from here back to here. And that's an anterior. So now that and I wouldn't have taken near that long to determine I'm going to adjust her, but I just wanted to show that. I'll go to a strong indicator muscle clear on the other side of the body. And then I'm going to challenge. Let your neck relax. So I'm going to challenge C4-5 just in general back that way. And that doesn't show, and that's a rebound challenge, but maybe I'll go a little more. Okay? Yeah. Just kind of really pull that around. And there it is. Now, another way I could do this, have UTL, take 2 fingers and touch right there at the lower area. And anteriorities will TL towards the anterior. There it is. So I'm just showing you several different ways to get at that. Just like you could, if this is weak in the clear, you can do different things and see if it turns on. If it's strong in the clear, you can do cervical compression. We could even go over here to this strong on the other side muscle and cervical compression, also weak in that. So in general, her neck's not real happy.
Yeah.
Make sure I'm not irritating.
No, you're good.
So the correction is going to be from A to P and to some degree S to I. I can have you lay on your back.
Do you want the taller table?
Yeah, let's do that.
So only anteriorities will test with compression. Only anteriorities. Like fixations won't really, subluxations won't.
Oh, subluxations will. Yeah, an anterior is a subluxation. It's an anterior subluxation. I mean, nothing's ever complete. Like you could push, you might have a sore spot on your head, patient might have, and that might trigger, there could be cranials that you're activating. But for the most part, and that's why you want to make sure you're doing enough compression that there's a little bit of change in the position. That's what you're looking at. Yeah, so that is your question.
Yeah.
So if you guys want to gather back, is that okay if we address that?
Yeah.
I'm going to do it respiratorily. Doesn't really might have to be a little more aggressive. But you guys have all had quite a bit of adjusting. No. Now, there's a ton of things we don't know about. Eyes are looking straight ahead. She's got no batteries on her. Pulse points, something going on that side. Middle pulse point. seems often the woman shows up. So we'll kind of keep that in mind. The right leg is a little short. Is it short?
No,
Okay.
it's not
So
sure,
it's a
but
little functional short.
yeah, I just myself.
What's that usually?
Yeah, it's usually
So do I have a category 2 here I need to clean? Yeah, looks like I do. Short leg, upper fossa, tender.
Yeah.
Okay. So everybody's got cat 2s. Somebody grab me the blocks. We'll clear the cat 2, otherwise it'll be fly in the ointment. Now, the position of these, the position, sometimes we can get fooled by our visual. Now, if you look at her hip bones, well, now it looks normal. You can see where this looks like the AS side, which it is, and this is the PI side. Though sometimes if you, and this is the short leg side, so that makes sense. Sometimes you'll see that, and one side will clearly be rocked back, and it doesn't match up what you see. And that's when you got to step back and think. Okay, so they're gonna put you up on blocks. Also, is the quickest way to sometimes just do both sides. Do a little challenge, make sure it's the issue. Seems finicky to fine tune the blocks, but it can make a big difference.
I just felt it move.
You did? Okay. And your legs evened out. That was easy. Go to the upper fossa and you're done. Now, so where were we? Oh, interiors. So it's, you can use any muscle you want, but Venus, I'll come up here. I'm just going to go up here. I'm going to statically challenge her. Statically challenge here, not so much here. Okay. I'll go to that C1 challenge. So left C1 seems to challenge somehow. So what we want to do interior. So I am going to she actually does need a little. That's my neck. So when I adjust those, take my time, I get this hand clear underneath this way. I'm getting on the side of the vertebrae. I'm going to guide it back to its proper position. So I'm kind of on that, pulling it from behind. I'm going to traction with these two hands.
What do you do with your hand under? You said you're like pulling.
I am, see my fingers? Right here. My fingers are spinous, and then I get right on, and then I roll it this way. And I'm guiding that towards A to P. This hand comes in and kind of supports that and then tractions. And I do the adjustment. And then, sometimes they go big old splats, sometimes they just go like that. Then I'll retest and see if I'm going to statically challenge the interior. I'm going to go above. She's got a fixation on this. And so that I will gently come around, and that's a P to A. With that one, I come in and you see my contact here. And I'm right over those facets. And I'm not going to take any chances. Okay. that in.
Nice.
I think you pumped every single one.
Maybe sometimes you know stone unturned. So challenge that again. Not challenge. If in doubt, always challenge again. Sometimes you got most of it, but not all of it. If you get it, not all of it, then do the rest respiratory. Something like that. So something I skipped that I was going to mention, I forgot. Before I said I was going to do it respiratory, then I decided to do it osseous. So, but before you do that, what we need to do is we need to check to see if she has ligament stretch. She doesn't seem to show that, so but I should have checked that before. If she had shown ligament stretch, I might have done respiratory first. And if that didn't get it all the way, then we went 0 to.
And then for like infections, you have to check her adrenals.
What's that?
Do you have to check her adrenals too?
If she had ligament stretch?
Yeah.
Definitely, yeah. And she does have, those points do show. But all of you guys,
Yeah, we're tapped.
mine do too.
On the anterior, so you were doing your vector with left and tissue, but
Pretty much.
okay.
How about if anybody that wants to, I'll set up on you so you can feel it. It's easier than when I went into your cranials. I have to change gloves each time. Let's see what that changed. Then, what else would we have? We had, sit up for me, because we had a bunch of interesting stuff. We had a serratus, we had a tricep, we had a tricep, and that's pretty stout. Now bend your knee, elbow a little bit right there. That's pretty darn stout. Stop. We had a serratus. That's strong. We started out because you had told me that you had an atlas. You had to close your left eye.
Oh wait, sorry, that was my right eye. Try again.
She still does. So I didn't escape. Now eyes straight to the right. And that was positive before.
Sorry,
before
yeah,
she
I'm
got
like
there.
staring right at it.
So eyes down. That showed before, and it does it now because you cleared the cat too. Right? So she still got it. You still got it, and that TL, Dr. TL, that left atlas. So how? So I still want to clear the atlas, laying back. And I've done a lot of yanking and pulling on the neck. I don't want to.
Are you gonna respiratory it then?
I'm hoping I can. When's the last time you had that adjusted?
Well, I
Yesterday?
crack it about every morning,
Okay.
and it stays for till about noon, and then it comes back. Yeah, that's
So she's got, her rectus capitis posterior major and minor. Those are the big ticket muscles in the upper shoulders. And the obliquus capitis superior and inferior. Those are the muscles. And also the longest colli that comes up the front of that way deep. And I do test that muscle. Teeth together. And Tim, I learned that from Dr. Francis years ago. That a lot of times that test that longest call. Since we're at this juncture, she's got an atlas, and we know all these discussions. See, she's got an atlas. Now we don't know if it needs. I have a feeling it needs. A little lateral challenge, lateral a little bit. Actually needs a little bit. What'd you say it was? Interior.
on the left. You're just saying it's forward on the left. When you feel the TPs, you can feel the TP left.
Yeah.
You can't feel the TP on.
Yeah. Yeah.
So if anybody wants to feel that, you can. Kind of weird.
Okay.
Yeah.
You guys want to feel her atlas? Be gentle and kind.
Right here.
Guide them.
Stick your
Did you
finger in
know?
that hole, and you'll feel.
Remember with your palpation, not this, not this. If you're ever
You feel that hard there?
wanting to test your palpation, palpate yourself.
It's been
I know where you're going. Yeah, I know where you're going.
Yeah, I use like, if it's like this, I should
They have, they have Yori malformation.
They actually don't. They're not even tested as but there's a big headache, migraine issue, and somebody's like, oh, you just have like all the muscles tighten around it. And so they did yeah, and there's some issues that I mean, I said higher, yes. So Alzheimer's, and I was like, I feel like that's what you shouldn't do it on.
That move is, it can be for fat.
I'll take my slides.
I don't have the knowledge in this, so like I
He-
just don't fully understand the concept.
I know who you are. That's right, that's classic. That's a classic thing.
Like not the same.
When
Like, oh,
Mike
there it
was-
is.
Anybody else? Here. Okay, everybody felt the neck that wants, okay. So let's see if it still heals. Maybe one of you magically heals. Not still there, okay. Now, why I wanted to stop at this juncture is because we have this atlas, and because the atlas is so profoundly connected to everything else, and we have this real high concentration of mechanoreceptors. If there's anything else before I adjust that atlas that might be, I'd like to find that, because once you adjust the atlas, a lot of those things clear out pretty good, and you won't find anything else for a while. They have to go walk around and stress themselves a little bit. Anything else going? Are we cleared a tattoo? Anything going on in the rest of your spine?
I don't think so. I mean, my two main problems that I have are this going posterior, and then I really like push it forward and like twist my body, and I can feel it pop back, and then these will be even again. And then my C, or just my neck, my
So-
C1.
Push out. So we'll do a little experiment. We'll adjust it before we do it. Go ahead, push out. Okay, that's strong. Push out.
Are you testing for fixation?
What's that?
Are you testing for fixation right now?
No, I'm just looking for a good indicator muscle, a good big indicator muscle that's a long ways from her neck. Go ahead and touch your left lateral mass. Yeah. So we get a positive TL. We kind of expected that. Now go ahead and breathe in. Push out. And breathe in. So the TL is negated by breath in. So using respiratory but I'm going to go ahead and challenge it again. It was kind of but really there's a little bit of SI this way. So it feels anterior, but I'm actually going to adjust it that way. Okay. So and it's on an in breath. So I'm behind. Here's her lateral mass. I have to get around behind, right on the base of her skull, to get behind it with your arch. And then I'm just going to have you breathe in as I do the motion that challenged. Okay. Good. And I'm tractioning to a bit with my lower hand as I'm turning. There we go. There we go. And once more, breathe. Still a little bit. Okay, so breathe in. That's more traction than any breath. Good. I'm gonna give this a tiny scoot that way just a hair so we're straight. There we go. Your thumb. And, oh, good, good. Go ahead and touch the C2 there. And then if you can reach over and touch the side. Then come around and TL the interior that we. That's pretty good. We have to sit. So far, everything seemed clear. Hold there. Close your left eye. Close your right eye. Eyes open, look up, right? Up to the left. Down to the left. Down to the right. Okay, cool. Yeah, so that would be all I would do at this juncture.
Why did you have a user thumb?
It's more neutral electromagnetically. I like either this, maybe this, or this. I don't like this.
Oh, because it was such a small space, like you can't really get two fingers in there.
It's hard to, yeah. And the thumb's neutral and it can get in. And this is really crucial. This is like if you want them to TL this way, a lot of times you'll miss it. It's just you need these pads. They're very energetically. Yeah. So cool. So and that's the typical anterior cervical finding, and that's how I would typically adjust it. Yeah. Thanks for showing up with that.
Of course.
So sacral wobble. We any more questions on that? First rib. Huh? Anybody have a first rib that's out?
I think we should come right first.
Oh, you really?
Yeah.
Oh, okay.
Unless
No,
I don't have the lunch. That's fine. Yeah, I was gonna say, I feel like our names are
You still have one?
Yeah.
From yesterday?
Yeah, just gotta, some people just.
Oh, look at this. Plates, yeah. So lunch. Yeah.
No, I certainly.
Oh, yeah.
Oh, I know that.
Split the sandwich is good.
Oh, it's kind of hard.
Because I saved it.
Especially when it's really soft. You may have to adjust it off. But everybody's a little different. My office is about still less than none of us. And she's been she doesn't. Of course, she stays on. She's a number of things she has to do to stay on. Yeah, that ligament stretch is so easy to do. And it will change. The weird thing is people test for it and go through it, do their trainers, get them all adjusted, get their system back up, and it will not fail to show. But it still tells you they need support. It's real to get. Temporarily bring them back up.